Hello everyone, I'm Steve Walker and I'm with Fleischman Hillard International Communications. And on behalf of bioMérieux, I'd like to welcome you all to the first in a series of 3 webinars designed to educate clinicians involved in sepsis management on the role of procalcitonin. Our webinar today is going to focus on the critical care physician's perspective and will be led by Dr. Devendra Amin. Dr. Amin is Assistant Professor of Medicine in the Department of Family Practice at the University of South Florida and Medical Director of Critical Care Services at Morton Plant Hospital in Clearwater, Florida. Dr. Amin has authored numerous scientific papers on respiratory health and has significant experience with procalcitonin in his institution. So for the next 35 or 40 minutes, Dr. Amin will share information about procalcitonin and how it can help take the guesswork out of early treatment decision for your suspected sepsis patients. Following in the presentation, he will welcome your questions. So with that, I'll turn it over now to Dr. Amin to begin our presentation today. Dr. Amin?
Thank you, Steve, for the introduction. Good afternoon, everybody. Thank you for joining us. The next slide is going to demonstrate a few disclosures as a consultant speaker of bioMérieux and speaker for Actelion. We've been using procalcitonin in Morton Plant Hospital now for about 18 months. The hospital is a 450-bed non-profit hospital, part of a 4-hospital system, which is part of a 9-hospital regional system. And we introduced procalcitonin to help us with our sepsis protocol. And I think we've been using it to good effect. I'd like to share some of that experience over the next 45 minutes or so. Sepsis is a major problem nationally and internationally, as you're all aware. It's a systemic inflammatory response to infection. Its incidence is increasing. It's the 10th leading cause of death in the U.S. It's a very common cause of progressive organ dysfunction. It impacts on the cost of care and increased length of stay. The incidence is on the rise because of the increasing number of elderly patients, increased use of invasive and diagnostic procedures, increased use of immunosuppressive and cytotoxic agents, increased number of immunosuppressed patients. Bacterial resistance is becoming a larger problem, and there's an increased awareness of the problem, too. If you look at this graphic, looking at the incidence, looking at the y-axis on the left, the incidence per 100,000 is increasing through time and through age. If you look at the mortality rate, as we get older into the 4th and 5th decades of life and onwards, the mortality rate goes up almost exponentially as opposed to the almost linear increase in incidence across age. So it's a significant and progressive process in life. If you look at the incidence when compared to other major diseases, severe sepsis is seen in approximately 300 per 100,000 of the population. In children, it's 20 per 100,000. And in the above 85-year-old group, it's 2,650 per 100,000. Clearly a major impact on hospitalized patients. Compared to breast cancer, colon cancer, and AIDS, all significant in their own way, but numerically not as many. Graphically, if you compare the incidence of severe sepsis with congestive heart failure in cases per 100,000, breast cancer, colon cancer, and AIDS, it is clearly a major problem. And these are from 2001 data from a large study produced by Angus and his colleagues at University of Pittsburgh. Similarly, from the same study, looking at the mortality of severe sepsis, it's very high, as high, if not higher now, than what we see with acute myocardial infarction. As the progression of disease goes from SIRS, sepsis, severe sepsis into septic shock, the mortality rate increases. As you see, the mortality rate in the graphic there, ranging from 7 to 10% up to 46% or higher with patients developing septic shock. Similarly, as the number of organ failures increases, the mortality rate increases from less than 15% if it's a single organ failure or less, or to 70% or more if there are 3 or more organs involved. The other information from this particular slide shows that ICU admission after the onset of sepsis produces a much higher mortality rate in excess of 45%, but if you happen to get the ICU before the onset of sepsis, the mortality rate is somewhat lower. So the incidence is significant, 2 to 5 per 1,000 hospital patients, 3 to 5% of medical ICU patients, and 9 to 16% of all surgical ICU patients. This is from data in 1995 to 1997, and also from Dr. Angus's data that we saw earlier in 2001. The mortality rate overall hasn't really changed in the last few decades. It ranges between 30 and 50%. It's the main cause of death in the non-cardiac ICU. The 1995 costs were about $22,000 at that time, is now approaching $35,000 per patient at this time in 2008-2009 figures. This Venn diagram shows the relationship between inflammation, severe inflammatory response syndrome, infection, and where there's an overlap, you may have sepsis or severe sepsis. Clearly, there are other reasons to develop SIRS symptoms, ranging from burns, trauma, or pancreatitis, or other injuries. So the initial presentation can be somewhat blurred as to what's actually causing the problem before you can actually home in on the diagnosis of severe sepsis. However, some of the definitions in SIRS and the SIRS criteria, you're probably all aware, it basically is a temperature elevation or reduction from normal, tachycardia, tachypnea, as well as leukocytosis or 10% or more immature or band forms. Sepsis is SIRS plus infection. Severe sepsis is sepsis plus organ dysfunction. And septic shock is seen in severe sepsis with persistent hypotension despite adequate fluid resuscitation. So what makes the problem so difficult? SIRS criteria are very nonspecific and present in many patients independently of sepsis. Microbiological proof of infection is often negative and the availability is delayed. This results in overprescription of antibiotics and possibly extended duration of antibiotic treatment, resulting in development of antibiotic resistance, nosocomial infections, and increasing cost to the system. Overall, severe sepsis is underdiagnosed, and sepsis can occur throughout the institution. The historical focus has been on supporting failing organ systems rather than on identifying the underlying disease. There's no clinical definition that can be applied at the bedside, and really there's no single test or marker that we have to define sepsis. And the patient population is heterogeneous. Patients come into the emergency room, with various different symptoms and signs, and don't often say they're septic. So it can be very difficult and challenging diagnosis to make initially. This one study that I'd like to share was published in Critical Care Medicine 2006, published by Kumar et al. And really what they saw with this study was, what they looked at was to look at the effectiveness of antibiotic therapy in patients and the timeliness of antibiotic therapy in patients who were defined as being hypotensive on arrival. It was a retrospective cohort study performed between July of 1989 and June of 2004, involving 14 intensive care units, 4 medical, 4 surgical, 6 mixed medical surgical units covering 10 hospitals, some academic, some community, involving ICUs in the United States and in Canada. They reviewed 2,731 charts with adult patients in septic shock, with no interventions. What they found was that effective antimicrobial administration within the first hour of documented hypotension was associated with increased survival to hospital discharge in adult patient septic shock. Despite a progressive increase in mortality rate with increasing delays, only 50% of septic shock patients received effective antimicrobial therapy within the first 6 hours of documented hypotension. This graph clearly shows the significance of this study. If you received antibiotics in the first hour, your survival rate was significantly improved at 78.9%. If you delayed treatment with antibiotics, for every hour of delay, the mortality rate went up by 7.6%, or survival decreased by that amount. The median time to effective antibiotic delivery was about 6 hours in this review, and the 25th to 75th percentile numbers were between 2 and 15 hours. So this brings home the point that early diagnosis, early intervention is key to survival. So for every hour's delay in diagnosing and administering antibiotics, the mortality rate goes up by 7.6%. Quite an incredible number. We're all aware of the golden hour when it comes to trauma. Clearly this applies to sepsis as well. So what do we have right now? The biomarkers of infection that we use right now are essentially gram staining, cultures, which are only positive about 30% at a time. They take hours or a couple of days to come back. We use white cell count, CRP, and a newer reagent that we have with procalcitonin. We also have global indicators of tissue perfusion to help with confirming the diagnosis. We look at serum lactic acid. We can look at mixed oxygen saturation. And all these help guide in our early recognition and management of sepsis. Perhaps this was best summed up by Roger Bone, past president of the Society of Clinical Medicine and CHEST, saying rather than trying to find the magic bullet to cure sepsis, maybe the focus should be on early recognition. So what is the ideal biomarker? The ideal biomarker should be objectively measured and be reproducible. It should be an indicator of normal physiologic processes, pathogenic processes, pharmacological response to therapeutic intervention. It should reflect the underlying biological process, predict clinical events, should be easily obtainable, reproducible, and affordable. Procalcitonin was FDA approved in the United States in 2008 and is intended for use in conjunction with other laboratory findings and clinical assessments to aid in the risk assessment of critically ill patients from their first day of ICU admission with progression to severe sepsis and septic shock. The SCCM guidelines, the Center for Critical Care Medicine guidelines for fever evaluation published in 2008, showed that there was a more sensitive serum procalcitonin assay now approved for the early detection of bacterial infection and sepsis in patients during their first day of ICU admission. Viral infections, recent surgery, and chronic inflammatory states are not associated with a significant increment in procalcitonin levels. In 1993, it was shown that there was a strong correlation between serum procalcitonin levels and bacterial infections. It's a sepsis-induced plasma protein. It's induced primarily by severe bacterial infection, and procalcitonin, calcitonin, catecalcin fragments measured by antibiotic binding, as with the LUMI test or the PCT test now available, is how it is measured. It's a complex amino acid chain of 116 amino acids. It's encoded by the calc gene 1 on chromosome 11, producing calcitonin, procalcitonin 1, and procalcitonin 2.